Hi, I'm Dr. John McClanahan. I'd like to welcome everyone to our four-part series dealing with tools for staying sober, or as I like to look at it, is Now What Do I Do? Thank you and enjoy. A couple months ago, we did a couple of segments on what I call is I is or is I ain't, and it's signs and symptoms of addiction and how to know if it's a problem and that kind of thing. Well, this is a follow-up couple of segments that I like to call, what do I do now? Okay, I figured out it's a problem. How do I fix it? What's available? And we've talked about inpatient, outpatient, going to meetings, things like that. And what I want to do in this third segment is talk about some medications that we can use to kind of turn the volume down. And then we're going to break it at right after this. And then at 6 o'clock, we'll come back and do the last segment, which is kind of internal tools for staying sober, like being patient and things like that. And we'll do some work with that in a session together too. So it's good to have you here, Brad. Glad you're here. Glad you're here, and glad y'all are here too. I didn't mean that, but I know you guys. But if you're ready, we can go ahead and do this piece. Okay, well, I want to welcome everybody back. We're going to do the third segment of Tools for Staying Sober, or Now What Do I Do? We've talked about, what I like to look at is external tools for staying sober, things where somebody has to be involved, not only the individual, him or herself, but something that usually takes other people, again, going to inpatient treatment, outpatient, meetings, church, something that involves other people other than just the individual, him or herself. In the last segment that we're going to do here in a little bit, we're going to focus on internal tools, things that the individual, him or herself, can change, attitude, way of thinking, way of approaching things. So things that don't necessarily need other outside support. And the two hand in hand work really well, again, together. Well, I wanted to do in this segment the last part of what I consider an external tool for staying sober, and that's dealing with medications. We have a number of medications that we can use to basically turn down the volume on cravings and that type of thing. The more we have at our disposal, the better. And as we go through some of this, there's another little piece at the end that I'm going to tack on, but I'll kind of make note of it now. Please, and this is a personal concern of mine, it's a pet peeve of mine. Some of my best friends feel this way, and we just agree to disagree. If you're in recovery and you find you need some other assistance in terms of dealing with cravings, turning the volume down, again, that's another thing we had talked about in the previous segment. It's not a sign of weakness. It's a sign of strength. People say, well, you're just doing that, and that's a crutch, and that. So is all the rest of it. When you come right down to it, a crutch is something we use to support our weight until we're strong enough to deal with a situation. Somewhere along the way, a crutch got a negative connotation as being a weakness. It's not a weakness. So if you find yourself having to take medication, again, to turn the volume down on cravings, or to get through withdrawals, just to deal with detox, it's there for a reason, and it serves a very important purpose. So I want to talk about a couple of categories here. There's three basic types of medications that we look at in treatment. Some have been around forever, some have been around for a while, and there's some changes, kind of teaching an old dog new tricks. But these are the three major categories. We have medications that we use that basically are what's called an aversion therapy. We'll get into that in a minute. There's a group called an agonist medication, and there's something called antagonist medications. And we'll look at some examples of each one of these. The first one, and the one that most people are probably familiar with, even people that recovery is not an issue, they may not know the name, but they certainly know the result in the situation. Probably the best aversion therapy we have is a medication called antabuse. And antabuse has been around basically since the Second World War, so it's not something that's brand new, but it's certainly being used in a lot of other areas that it was never used for in the past. Basically, aversion therapy, I tell folks, antabuse does one thing and does it very well. It's an inert substance. It lays there and does nothing unless you add one ingredient. And if you drink on it, you're going to get sick as a dog. And so again, the aversion therapy is, if I do this and I don't want this, don't do this. It's a cause and effect. So antabuse is kind of the old war horse. It's been around forever. I want to kind of give you a little quick chemistry lesson of how this stuff works. Antabuse is used now in a little different way as well. It used to be what we called a primary therapy, okay, where a person was prescribed antabuse and you stayed on it the rest of your life or until you decided you didn't want to stay sober anymore. So it was a forever and ever kind of thing. Well, now we use antabuse in more of what we call an adjunct therapy. It's used as a safety net until the person gets comfortable going to meetings, going to group, going to therapy, going to church, whatever it is he or she decides they need to do. So it's there as a stopgap. It's not a permanent type of thing. So what antabuse actually does, it's a sulfur compound, and one day when we have time, we'll maybe do another little segment of this, and I'll tell you the history of antabuse, because where it actually came from has all the makings of a great spy novel. It was what we call serendipity. What it was used for has nothing to do, or what it was developed for has nothing to do with what it's used for today. In kind of real quick, antabuse, actually the basic product, it's called disulfiram, that's the chemical name. And actually it was developed during the Second World War to help cure rubber so you could have tires cure faster to be put on planes and Jeeps and to support the war effort. Had nothing to do with a stopgap for treating addiction, but that's where we've kind of ended up with it. So anyway, one of the things that antabuse does, again, it's a sulfur compound, and it has a very unique action. If you look at how alcohol detoxes, now I'm not talking about being in detox, just if a person has a couple beers watching a ball game, this is how the body eliminates it. It's a two-stage, two-step process, okay? Very simple process when you look at it, okay? And I promise you'll never have to remember this word. Okay? Alcohol is broken down into a substance by the liver called acetaldehyde or acetaldehyde, depending on what part of the country you're from. And then that's broken down into two substances. Acetic acid, which basically is vinegar, and water. So you take something that's toxic and irritating to the body, and this process, the liver converts it into something that's pretty inert, pretty harmless, and then eliminates through sweat or urine or a couple other ways. But basically you're taking a poison and turning it into two substances that are harmless. Okay? Now the trick is, alcohol is an irritant. It's a poison. Again, that's why we talk about detoxifying. You're depoisoning the system. Whether you're talking about having a couple of beers at a ball game or you're talking about detox in a facility, the same process is happening. In order for alcohol to convert to this, it has to go through this stage here. And this is a very quick shift. Okay? The liver produces an enzyme called acetoamylase, which is what the liver uses to break this down. Okay? Also, to break down this into this, it's another enzyme it produces. And I always tell people, as corny as this might sound, if you want to remember the name of this, just remember film speed. Think of Kodak or Fuji or somebody. Okay? The enzyme is called cytochrome P450. And I don't know why, maybe it's just me, but I always think of a camera and film when I hear this term. So cytochrome P450 is what the liver produces to break this down into this. Now what antabuse does, and kind of the dark beauty of antabuse, it interferes with the liver's ability to produce that. And if it can't produce that, it can't break this down into this. Now this is a very strange twist in chemistry, where God's got a bizarre sense of humor, or however you want to look at this. In order for this toxin to be turned into something harmless, it produces this, which is more toxic and more of an irritant than what it's trying to get rid of. But because that shift is very quick, the body doesn't really have a lot of repercussion from it. If you can't produce this, you don't break this down. And if this doesn't break down, now you start to get the irritation effect. Antabuse is very specific to the individual. A person doesn't know how they're going to react until they're in the middle of a reaction, and it's too late to say, wow, I shouldn't have done that. So it's kind of that aversion therapy of, I might want to do this, but look at the consequence. Maybe I'll, not today. Okay? So it's there purely as an aversion. If I do it, I'm going to pay a consequence. Now the problem is most people might think, well, how bad could the consequence be? That's the other dark beauty, is you don't know. Okay? And you talk about being wide open. It can go anywhere from feeling like you're coming down with the flu, a little nauseated, a little flush, that kind of thing, to respiratory arrest, and a whole lot of in between. So again, you don't want to find out, spin the wheel and let's see where this is going to land. It's, if this is in my system, I think I'll pass. Okay, I think I'll just wait. We are all sensitive to this substance in different ways. I had a patient years ago that, to show you how sensitive, I knew she was on taking antabuse to help deal with her early recovery, and she comes to group one night. She's sitting there in group, and during the course of group, she started to get more red, and I mean just almost like a beet. I mean, she almost glowed. And I thought, something's wrong, go figure. And I took a break. I said, let's just take a break for a few minutes. And I went over and I asked, are you okay? She said, no, I don't really feel good, and I don't know what's the matter. And I said, well, come down the hall. And I took her blood pressure, and it was really high. And I said, look in the mirror. And she was red as a beet. She goes, oh my God. I said, we need to get you down to the emergency room to check this out. And I had to ask her, and it's a question counselors hate to ask. I have to ask you, have you been drinking? Because I knew she was taking antabuse. And she said, no. Why would you ask? And I said, well, your blood pressure's up, you're red as a beet, you're sweating, something's happening. I haven't been drinking. We get down to the emergency room, and they can't find anything. And one of the ER docs asked her a couple things about, what did you do prior to coming to group? Now this was back in the day, it was back in the 80s, when everybody had big hair. Okay, this was like 2 cans of hairspray, big hair. She was so hypersensitive to the antabuse and the alcohol, she was getting enough alcohol being absorbed through the lining of her scalp that she was having a reaction. Now today you wouldn't, because back then in aerosol sprays and that, they used alcohol as a propellant. And it also helped kind of keep the little hole free from getting gummed up. They don't use that for that anymore, but there was just enough that was getting in there that she was having a reaction. I had a friend of mine, been in recovery for years, works in a body shop, he's a painter, had a massive antabuse reaction, had the respirators and all the ventilation was working. Got enough alcohol in his system from absorbing the paint thinner in the air. So some people can get nauseated, some people can have major problems. I always tell people, please, if you decide antabuse is something you need to take a look at, if it's prescribed to you, make sure your doctor or the pharmacist gives you the book that goes with it. There's a little booklet and it's got a name like So You've Decided to Take Antabuse, and it's an orange booklet, and it's probably 60, 70 pages long, not to scare anybody away, but it's all the things in there that you have to stay away from. Mouthwash, salad dressings, things that could create a reaction, severe or not. I always tell people, if you want an idea of just how sensitive you might be to antabuse, do a test patch. A lot of times people say, well, you know, I wear perfume or cologne or aftershave. Okay? If you want to find out how sensitive you might be, take your perfume or cologne or whatever, do a test patch. Put a little bit of that cologne on the inside of your arm or maybe the inside of your thigh, somewhere that only you are going to see it. And if you're hypersensitive, it's going to kind of welt up almost immediately. It'll give you like a rash. Okay? I've seen too many times people forget and they'll splash on their aftershave, and by the time they get to work, you know, again, they're red as a beet, and what happened here? So, you know, if you get that little, if you're not hypersensitive, you're probably not going to get much of a reaction at all. But if you get, like you're allergic to strawberries or something and you get hives, you'll know almost immediately. So give yourself that opportunity. One of the things that makes antabuse so unique is its action. And I think this is one of the kind of the classic things here. All medications have what we call a half-life. And basically a half-life just means it takes a little bit of time to get to its maximum performance, and it gets to that peak and then it kind of peters out and then it's gone. Okay? Most medications, even aspirin, have a half-life that look kind of like that. Kind of that, you know, that bell curve kind of shape. Okay? Where you take it here, it's maximum here, and then it starts to lose its effectiveness, and then you have to take another one. Okay? There's a heart medication I take every day, and when I first got prescribed this medication years ago, I had to take it 3 times a day. Well, they came out finally with what they call an SR, a slow release, so now I take it once a day. It's the same dosage all at once instead of taking it 3 times a day in smaller doses, and it just slowly, you know, the body absorbs it and then it's gone, and then I have to take it again in the morning. Most medications work like this. Watch Antabuse's half-life. Okay? It's absolutely kind of an amazing thing in kind of a dark way. Okay? Person decides today's the day I'm going to start taking Antabuse. And they take that first dose, and maybe somewhere in that first dose they realize, oh my God, what have I done? I don't trust myself. What if I do drink? What if I mess up? Oh my God. Let me hang on till tomorrow. And if I happen to, then at least I don't have this to contend with. Watch the half-life of Antabuse. It takes a couple of hours for it to actually get into into your system and where it needs to be to work. To show you how, when people talk about go to any lengths, I had a guy not too long ago say, okay, so if you take it here and it takes a couple hours for it to, I got that window of opportunity to, it's like, you got a whole lot of work to do. You know, Antabuse might not be the answer here. So here, this is how this stuff works. Okay? You take it, a couple hours later you decide, again, it's not for me, I've made a mistake. Tomorrow, maybe if I choose poorly, I won't get as sick. Okay? 24 hours after you take that first dose, you're going to get just as sick as the first couple of hours. 48 hours, you're going to get just as sick. 7 days, you're going to get just as sick. It's one dose. Okay? 7 days, you're going to get just as sick. 10 days, you're going to get just as sick. Now, depending on our individual chemistry, Somewhere out here around 12, 13, 14 days, it's gone. Okay? One dose gives us that kind of protection. Now, the good thing about it is, well, people will say, well, if I'm taking it, and it lasts that long, why do I have to take it every day? Well, part of it is a psychological thing. I need to do something on a daily basis. A lot of us, our short-term memory is not as good as it should be early in recovery. Did I take it yesterday? Or was that last week? Or when was it? If you take it every day, you're building up, and it's not a medication that you build up a toxicity or a tolerance to. It's not like, well, I'm going to overdose on my Antabuse because I take it every day. Basically, what you're doing is every day you take it, you're extending out here a day. So it's giving us that protection. Again, it's an aversion therapy. It does one thing really, really well. If you drink on it, you're going to get sick. How sick, again, depends on you individually and that type of thing. I think it's also, like I said, I've had people mention to other people in recovery, in group and in meetings, while you're taking Antabuse, you're half-stepping it. Okay? I didn't have to take it. Not everybody does. The only person that knows how good or bad you're feeling, how well your recovery is going or not going, is you. And if you feel like you need that little extra insurance, there is absolutely nothing wrong. Like I said earlier, somewhere along the way, the word crutch has gotten this very negative meaning. Yes, Antabuse is a crutch. So is AA. So is group. So is church. So is therapy. Anything we use to help strengthen us, to improve our well-being in our life, that's one of the definitions of a crutch. It's not a negative thing. And it's not saying, well, you're not working hard enough. Whatever you need is what you're going to need. Okay? So don't ever let anybody say, well, you're taking this or taking that or that. Again, this works by a whole different set of rules, and we'll talk about that in a minute. Because people very often say, well, you got to avoid all drugs. It's all mood-altering drugs. Antabuse doesn't do a thing. It just lays there. It doesn't make you high. All it does is it turns the cravings down a little because of that aversion connection. I can still choose poorly, but there's going to be a huge consequence if I do. So it gives us that. Very often, we were talking in a previous segment about this whole concept of delay plus behavioral alternative. And that's just a whole lot of babble for shift the focus, call your sponsor, say a prayer. More return to active use occurs in the panic of the moment. Before the person can finish saying, oh my God, here I go again, we're gone. If you can put something in to interrupt that, even for a split second, you stand a better chance of it not ending up in disaster. Just knowing this is there gives you that split second. Do I or don't I? I know what's going to happen if I do. Maybe not today. It'll buy us that little extra time. Antabuse, again, is not meant as a primary therapy anymore. It's used in addition to everything else that we do. And we'll talk about that in a minute too. So this is a great, again, old war horse, been around for decades, and it's still very, very viable. One of the things that I was reading an article not too long ago, they don't really quite know why this happens. One of the things that was very unusual for years, if the patient was alcoholic, we could talk about Antabuse. Here recently, can talk about naltrexone, which we'll look at here in a minute. If you were an opiate patient, we talked about naltrexone, and then over time, buprenorphine, Suboxone, and a few other things that have come down the road. For the cocaine addict, there really wasn't anything there to turn the volume down. It was basically God love you and good luck. I mean, that was, and go to meetings. That was all the person had. Well, a number of years ago, they started doing some research, just again as that serendipity thing. Let's see if this works. Let's throw everything we can at it. I had a friend of mine who's a neurochemist at NIH, and he's devoted his career to trying to find something for the cocaine addict to turn the volume down on cravings. And everything he's used over the years, hundreds and thousands of compounds, he's had two results, two extremes. It didn't work, or it worked so well, it was like a chemical lobotomy. It certainly turned the urge to use down, but it turned everything else down too. There's no middle ground. Well, somebody got the bright idea of why not. They started giving antabuse to cocaine patients early in recovery. They don't know the biology or the chemistry behind it. Even if it's purely a placebo thing, the rate of relapse is decreased. So there's something going on in there. It's doing something. Okay? They don't know the mechanism yet. So now all of a sudden, maybe there is something that can be used. For years, the medication that was used to treat cocaine addicts early in treatment was antidepressants. Zoloft, Paxil, things like that, because it was kind of the downside in withdrawals. And a person's up here, there's always the crash. And for every action, there's an opposite and equal reaction. So the depression was horrible, when the person would first come down. So they would treat them with antidepressants, and that would kind of raise that level of the crash and make it a little easier for the person to get through early recovery. So again, there's some things in the pipeline, but antabuse still is tried and true. A lot of people swear by it. A lot of people, it's archaic and we don't do that anymore. I'm a firm believer in whatever works. If there's something out there that works 1 out of a million and you're the one, who cares? Not to sound real mercenary about it, but who cares? If it's working for you, okay? There's a lot of other options we have, okay? There's a class of medications that are being used and been around for a long time called agonist drugs. And an agonist drug basically acts exactly like the drug you're trying to replace. The most common agonist drug that most people are aware of would be methadone, something that binds to the same receptors as the medication or the drug you're trying to deal with. Okay? It acts just like those medications. Okay? And then we have some extended versions. There's something called LAM, L-A-A-M, that's a slow release version that can, you can get it in a 3-day strength. You can get it in a 28-day, like a month in a patch, just like if you're taking insulin or something like that, and you have a patch you wear, so you don't have to go back every day to get your medication. So those are kind of agonist drugs. Suboxone is kind of in no man's land. It works kind of in both of these categories, but I think it's more of an agonist drug than anything else. But I wanted to spend a little bit of the time we've got left for this little segment talking about antagonist drugs. Antagonist drugs are very unique because what they do is bind with the receptor that your drug of choice would attach to. And basically, two things can't occupy the same space at the same time. So theoretically and realistically, if you look at and if you've been with me before, you know my artwork. Receptors look nothing like that, but just use your imagination. Receptors basically, if you look at what a craving is, basically a craving, the medical definition, of a craving is a response to a drug signal. And all that means is receptors open up and say, feed me. We put something in and it says, thank you very much. Some of you know kind of a corny comparison that I use. Receptors, to me, to give people a real world example, everybody in here has seen baby birds. Receptors are just like baby birds. Got a nest full of baby birds and they're sitting there with their beaks open and they're screaming and they're hungry, and mom flies over and throws up a little bit of worm into their mouth. And the receptor close of their beaks close, and it's like they're on a hinge. They spring back open again. They're never full. Mom finally gets tired of throwing up the worm and flies off. And they'll sit there for a little bit longer, and they're squealing and chirping and yelling. And finally they realize it's done. And they shut their beaks and they fall asleep. Receptors are just like that. They spring open, say, feed me. We put something in that says, thank you very much. Or if we ignore it, delay plus behavioral, do something else, they'll close on their own. Okay? What antagonist drugs do is we're kind of giving it that little piece of worm. Okay? We have a lot of antagonist drugs. The most common are naltrexone, which has been around for years, was originally developed to deal with heroin addiction. And they found out a number of years ago that the receptors for alcohol are very closely, they're in the same neighborhood as opiate receptors. And just maybe there might be a similar effect. And they did studies years ago and found out that taking a medication like naltrexone can reduce the relapse potential almost by half. But there's another piece that goes with that, and I'll mention that here at the very end. So again, it's something that basically if the person is taking a medication like that, Campril, which is another a form of an antagonist drug, basically what happens, it fills the receptor. So two things happen. The brain thinks it's used. The receptors say, thank you very much. And it attaches to the same receptor. But you don't get high. With agonist drugs, it attaches to the same receptor. But there can be a high that goes with it, or a withdrawal that goes with it when it's removed. You don't have that with antagonist medications. So basically, if the person, again, the brain thinks it's used, so why bother? Technically, if a person uses, and this medication is in there, doesn't have anything to bind to, and doesn't do anything. So there's kind of that no room in the inn kind of thing. You have to be real careful with how you use this medication because, again, addict math, if $100 didn't work, $200 will. You know, if $200 didn't, $500 will. Okay? You can use enough of the drug of choice to basically, finally, push this medication out of the receptor. But generally, that amount of medication or that amount of drug of choice also is going to probably going to lead to overdose and possible death. So one of the strange things about this medication, opiates, alcohol as well, can't push this out of the receptor, but this can push the other drug of choice out of the receptor. If you ever watch TV shows, whether they're staged, dramas about hospital life, or if you're watching real life in the ER, a reality type of thing, every so often they'll bring somebody into the ER that's maybe unconscious or what, and you'll hear somebody call for a Narcan push. What they're doing is the person is overdosed on something, usually an opiate of some kind, and they'll use a Narcan push. What they're doing is introducing a massive dose of naltrexone into the system, and it pushes the opiate out of the receptors, and the person will come to a lot faster. It just flushes the receptors. So it can be used in that sense as well. There was, in the area here a number of years ago, there was a particular probation officer. They retired a long time ago. He called me one day, and somewhere along the way he had read about a Narcan, or they call it a Narcan challenge. And he said, I think I'd like to get together with you, and I have people that I think are using. This was before you had the day of the instant cups and that type of thing. You had to send the test out to the lab. He said, I've got a couple people that I think are kind of getting over on me, and I would like to send them to your office and have somebody on your staff do a Narcan challenge. And I said, what are you, crazy? And he said, well, yeah. He said, I've heard that if you, I said, yeah, and you can kill the person doing that too. What he wanted to do was, I think Sally's using, I'm going to send her right to your office, and if she's using, she'll go into withdrawals immediately, because this stuff would push it right out of the receptors, and they'd go, and it's like, that's malpractice. But he was thinking, this is one way to use this stuff. So, people come up with some bizarre ways to use things that are meant for a good purpose. So anyway, one of the things when we look at any antagonist medication, it's there like anything else that we use. If you look at the labels of any medication like this, Antabuse, any of the medications that are available, you'll see in the print, this works best if used in conjunction with treatment, meetings, all the above. It's not an end-all be-all. It's not a cure. It's not the magic bullet. It's just one more thing that gives the individual an opportunity to turn the volume down on the craving so they can take advantage of meetings, group, church, all the above. Okay? There's one other category real quick of medications that I wanted to mention, and this is a real pet peeve. And I just cringe every time I hear somebody say this. And I know I'll probably hear, because I always hear back because I make this statement, but I can handle it. I get so irritated when I hear people in meetings or in group, somebody will talk about they really need to get to their psychiatrist because their prescription ran out on their antidepressant or what, and somebody will say, oh my God, don't you know it's an all or nothing drug-free program. It is to a point, okay? Very often, you've got purists in recovery, and God love them. If this works for them, that's fine. If you have a headache and you take an aspirin, you've used. To me, that's like telling the diabetic, well, you're in recovery now, congratulations, but that insulin stuff, that's got to go. Well, that's not going to. Bill Wilson, one of the last things he wrote, co-founder of AA, one of the last things he wrote was a little pamphlet called Recovery and Other Medications. One of the greatest things I think he ever wrote, because it talks about that. People took the words early on of it's all or nothing, it's a drug-free program, and twisted it. It talks about mood-altering substances. The alcoholic can't say, well, I'm not going to drink anymore, damn near killed me, but I never tried cocaine. Let's bring that on and see what happens. Or the heroin addict say, well, I'm not going to do that, but it's okay to drink. That's an all or nothing. It's a mood-altering. Medications that we use to treat depression, bipolar disorder, anxiety, those are mood levelers. You don't get high taking your Lexapro or any medication like that. What you get is balanced. So if somebody says you're not really in recovery because you're taking antidepressants, thank them for their concern and keep doing what you're doing. Because very often, again, if you talk about a situation like a dual diagnosis, where you do have a documented mental health issue and a documented substance issue, recovery in one is so dependent on recovery in the other. And finding that medium in between is what's going to put the quality in the person's life. So if a person's taking medication to deal with depression or some other mental health issue, to me that's no different than a diabetic taking insulin or any other medication that's used for that. You're using that to get stable, to get balanced and level, whatever that is for you as an individual. It's not a mood-altering substance. So again, if somebody says you're not in recovery because again, they're wrong. Thank them for their concern and keep doing what you're doing. I'm going to end this segment here, and next segment we're going to take a look at is internal tools, which I think are
Very important, very simple. Another one of those things, very simple to learn, sometimes very difficult to put into practice. And we'll end this segment here, and we'll see you back in a little bit. See you real soon.